Okay, so infection affecting the total shoulder arthroplasty, the surgeon perspective. Again, my disclosures. So infection rate is approximately 1%, and it's higher in revision surgery and higher in reverse arthroplasty. And again, it's probably much higher, as we heard from the previous speaker, because of the low-grade stealth infection with the P. acnes, or C. acnes called now, to confuse us. The classic signs of infection are by germs like Staph aureus or Staph epidermidis, but the P. acnes actually is 50% to 70% of common pathogens in infected joint replacement. It's a low-grade infection, no clinical signs of infection. The serum, ESR, CRP are usually normal, difficult to grow in culture, need longer cultures, and in histology, you don't get the 5 polymorphonuclears per high-power field. So it's much more difficult to find. And this is our classic paper that we published some years ago, that we found it in more than about 42% of virgin shoulders with osteoarthritis coming for shoulder replacement. And the question is whether it's underestimated etiology in the pathogenesis of osteoarthritis, or it's a cause for delayed postoperative post-arthroplasty joint pain, loosening, and infection. And if we look at it, actually, again, we found it in 42% of the cases, and again, the histology didn't show a 5 polymorphonucleus, but lymphocytosis. And if we looked at other studies that looked at revision of aseptic, so-called aseptic loosening, a lot of them were actually septic with P. acnes, like the one from Topolsky or the one from Levy, again, about 60%, 56.3%, Pottinger, again, 56%, and again, from the last paper from J.P. Warner, again, 41.2% of the patients were positive with P. acnes. So again, whether this is an unrecognized, if you have a painful shoulder, first of all, you have to think infected, and unrecognized low-grade infection at the time of primary joint replacement may be responsible for these painful shoulders and stiff shoulder and aseptic loosening. Type of infection, actually, we talked about it, the acute early postoperative, the acute late hematogenous from urinary tract infection, from other infection in other parts of the body, hematogenous, or the low-grade infection. And it's really important whether it's early or versus late, more than 6 weeks after. Again, always keep an eye index of suspicion, any chronic pain, stiffness, early loosening, osteolysis. Think about infection, think about P. acnes. And if there's macroscopic signs of infection, that's easy, not a problem. Redness, swelling, draining sinus, pus, eye fever, and positive markers. That's easy. That's not a problem. But always think about it. Now, microbiological diagnosis, the CRP is negative in 75% of the cases. The ESR is negative in 86% of the cases. The synovial interleukin-6, again, it's not great for P. acnes. The alpha-defensin is not great for P. acnes. Aspirate, again, is only positive in less than 50% or about up to 50% of the cases. Sonification can help. And an extended culture, always think P. acnes. Always think P. acnes. So as I said, this not really good for P. acnes. Again, if you can use it. If it's positive, yes, it helps you. If it's negative, it doesn't give you too much. What are the treatment options? The treatment options are arthroscopic debridement, washout, debridement, washout, and exchange of the modular parts of the implant, single-stage revision, two-stage revision, permanent spacer, resection arthroplasty, arthrodesis, or antibiotic suppression with no operation for the rest of the patient's life. So arthroscopic washout, actually, it's for acute early infections, ideally less than 3 weeks after surgery. The earlier, the better, and the better the results are. The best implants are the implants with less modularity, less parts, that you have less sanctuaries for the bacteria to hide. You may repeat it if necessary. You start an antibiotic regime, and you actually try to get the antibiotic to pathogen-directed specific dual antibiotics for at least 4 weeks. And as we heard before, the rifampicin is really important because these fight the biofilm. So whatever you do, it's dual antibiotics, either clindamycin and rifampicin or amoxicillin with rifampicin, because this actually covers the P. acnes as well. And this is actually, you can see here, this patient is 17 years after she had an arthroscopic washout for hematogenous infection after urinary tract infection affected her resurfacing. And I washed her early. And the first she called me, said that my shoulder is painful. I said, okay, it's probably infected. She had a UTI. I washed it, and this is, indeed, she had bacteria in the shoulder. And this is 17 years later, she's still working. Debridement, washout, and exchange. Again, acute early infections. Again, ideally less than 3 weeks. The earlier, the better. Exchange of the modular part. In this case, actually exchange of the liner and the glenosphere. And then what I use this implantable antibiotic-loaded biodegradable beads with calcium sulfate. It's called Stimulan, and it's actually full of antibiotics. That actually keeps antibiotics inside for a few weeks. And again, the same antibiotic regime with dual drugs. And again, this is the gentleman that you saw in the previous slide. 70% you could retain the implants, good range of movement, chronic antibiotic suppression, and early surgery is better results. Single stage revision. You have to, as we heard, we have to stop the antibiotics for 2 weeks before surgery. We take multiple microbiology specimens. We have to withhold antibiotics until we take the specimens. It's no brainer to give antibiotics before you take the specimens, because you won't be able to grow anything, or especially the P. acnes, which is very sensitive to antibiotics. You have to remove all the implants, including all the cement and everything, if you have cement. Do a meticulous debridement and washout like a tumor surgery, and reinsertion of the new prosthesis. And again, what I do is I use this implantable antibiotic-loaded biodegradable beads and antibiotic regime. And here you can see this gentleman that had a total shoulder replacement with his stemmed implant. He did very well. And then he had an infection in his toe. And this actually, what hematogenous went to the shoulder. And as you can see, he had this sinus in the front of the shoulder. He was referred to me with that. We knew it's a stuff. We did a single stage revision and washed everything. And we used the stimulant, as you can see here. I used the stimulant beads. I fill it into the canal and into the bone and around the tissues in different levels of the tissues. And this is vancomycin loaded. And I managed to revise him to a stemless reverse shoulder. This is how the immediate x-rays look like. And this is this gentleman a year later after a single stage revision. You can see that everything is incorporated. You can see that the canal has been filled with bone, so we actually now have a stemless implant with a complete resolution of the infection. Again, this gentleman was referred to me from Canada. He had a resurfacing, but he was painful. And the question whether he's got a low-grade infection, and we did a revision. Again, he had a glenoid erosion as well, but I think he was infected. We couldn't grow anything, but he, again, this is a Skype follow-up from Canada, and he gets good range of movement and no signs of infection. And again, this was a low-grade infection. Single-stage revision, you have to stop antibiotics for 2 weeks before. You get good clinical outcome although it thought to be inferior in the past to two-stage. The two-stage is the gold standard, but I think it's better than the two-stage. You have good eradication rate, up more than 90%, less surgery, less damage to soft tissues. It's better if you know the organism, but if you don't know, again, you have to assume that it can be the P. acnes. Fistula is not a contraindication. And again, there are less studies that have been published on that, but can be a problem if you need a bone graft. If you need a bone graft in the revision, and that's you may have to use a two-stage procedure. Now, this is just studies that shows the single stage, and you can see that the rate of success is quite high in the single stage revision. The two-stage revision is the gold standard. Again, the first stage is similar to what we did here, but we stop short of putting the implant. We just use an antibiotic-loaded cement spacer or a spacer, and we use the same. I use the same antibiotic-loaded biodegradable beads, and about 6 to 12 weeks later, do a repeat stage 1, so A to E, the same thing, and then remove the spacer and put the new prosthesis with the beads, and again antibiotic protocol with two drugs. Now, the two-stage is when the organism is not known. You have to keep the spacer and antibiotics for 6 to 8 weeks. The second stage is guided by the inflammatory markers and the aspirate, and you can do it. You can do first stage several times until it's clear, and only then do the second stage of reimplantation. You have to stop the antibiotics again 2 weeks before the second stage because you take specimens again, and you have to, overall, there are good clinical outcomes, and the eradication rate is overall good, but it's slightly less than the single stage. And it allows for infection control before allograft is needed or used. And this lady actually, she had previous multiple operations, and again, we attempted a single stage revision, but it didn't really work. And then we did a two-stage revision with implantation of this spacer. And this is after the second, 2 years after the second stage revision. Again, not great, but she's got reasonable function, and she's infection-free. And again, you can see this is the collection of the studies of two-stage revision. You can see that the success rate is slightly lower than the first stage. And there was a paper recently by a few papers. One was a two-stage revision by Zuckerman and his colleagues in 19 patients, 26 recurrence rate, P. acnes and multiple operation and longer duration of symptoms were worse functional outcome and high risk for recurrence. And again, this is again a systematic review in 2016. No difference in infection eradication rate, single stage, significantly better functional outcome, again, because less damage to soft tissues, less surgery, quicker recovery. And again, this is again what is better to do. So sometimes you have to leave a permanent spacer because you can't get rid of the infection, or the patient come back to you, is not so well medically, he can't have a more operation, and then you leave it there. Again, another option is resection arthroplasty, like this gentleman that had was referred to me with infected total shoulder replacement. And again, we had to do about 10 operations to get rid of his infection, and that's what's left. He wanted to persuade me to do on that reverse shoulder, but I eventually got my senses and backed off. There's a limit to what we can do. And this guy will remain like that with this shoulder. And again, poor results, but we can't do anything. And if it doesn't work, then you do a lifelong antibiotic suppression. So to conclude, you have to tailor the treatment to the patient. You have to keep an high index of suspicion, be aggressive with acute infection, act fast, and stop antibiotics for at least 2 weeks before surgery, and withhold antibiotics until you take the specimens, only then put antibiotics in. Take multiple micro specimens, and in our lab, we take at least 5, and if more than 50% are positive, then it's positive. Do a meticulous debridement and washout, like a tumor surgery. It's better if the causative bacteria is known, but always suspect P. acnes if you can't find anything, and consider the use of implantable antibiotic-loaded biodegradable beads. Thank you very much.